Okay, so today we're going to start a section on congenital heart disease, starting with the plain film approach. And the advantage of doing it this way is not that anybody expects you in real clinical practice to come up with a diagnosis of underlying what specific congenital heart disease the patient has based on the plain film, especially on infants. But this kind of approach has the advantage of it really helps you to organize your thinking about congenital heart disease and makes it easy to categorize and understand the different abnormalities. And so it gives you a very nice framework for organizing what can be, this very complicated material. So in terms of the plain film approach, an easy place to start is skeletal abnormalities, and in most cases that's not going to be helpful, but sometimes there's an abnormality where if you notice it, you can hit a home run from the plain film. Situs is something that may be an obvious abnormality on the plain film, and we'll discuss that in a little bit. The most important thing really, though, where you're really going to start in most cases is the status of the pulmonary circulation. And then the clinical information, whether the patient is cyanotic or acyanotic, and that's going to determine the differential pathway that you choose, your diagnostic tree, how you basically the algorithm that you use. And then the aorta and the pulmonary artery can be very important for pointing you towards specific lesions. Heart size and specific chamber enlargement, especially the left atrium, can help you when you're dealing with shunt lesions. Notice that we get to the heart pretty much near the end of the list. The most important thing where you start the discussion of congenital heart disease when you're talking about the plain film is you always start with the pulmonary circulation. So starting with skeletal abnormalities, the finding here is, and this is associated with, rib notching is associated with, yeah, of course, coarctation of the aorta, right. It's a very difficult thing to see, though, and sometimes you'll question whether it's really there or really not there. In most cases, it's going to be missed, quite frankly, on the plain film. But if you happen to notice rib notching and you're wondering about coarctation of the aorta, where should you look next?
Aortic contour.
Yeah, so you look at the aortic contour, and what is it that you're looking for?
The number 3 sign.
You're looking for a figure 3 sign. So if you think there's notching of the ribs, and you look at the configuration of the aorta, and this indentation here, this figure 3 sign, is a plain film finding that can be associated with coarctation. Obviously, very easy to see on any kind of imaging studies. So if you think you see rib notching, look here at the configuration of the aorta, looking for the figure 3 sign. What about the number of ribs? How does that help you? What do you notice about the ribs here? Well, how many ribs are there?
11 ribs.
So how is that important?
I think there are congenital anomalies that are associated with
Like
Down syndrome.
Sure, right. So endocardial cushion defects can be associated with Down syndrome. Down syndrome can be associated with 11 ribs. So you may have too few ribs, you may have too many ribs. A little bit of cardiomegaly here, some increased vascularity. So that was a child with Down syndrome. What syndrome is illustrated here?
Is this like Holt syndrome?
Yeah, so right. So Holt-Oram syndrome, where you have these radial ray anomalies, right? And the cardiac defects associated with that are, what are the cardiac defects associated with Holt-Oram syndrome?
ASDs and
Yeah,
VSDs.
so septal anomalies, right. So ASDs and VSDs, usually cardiac septal defects. Here, this patient has pectus, and that's, of course, easy to see on the lateral view. You'll see the sternum is displaced posteriorly, but if you only have a frontal view, what is the clue on the frontal view that you might be dealing with pectus? A pectus deformity. What is it we look for on the frontal chest radiograph? What are the findings on the frontal chest radiograph associated with pectus deformity?
You can have aneurysms of the ascending aorta and like Marfan, they're like Marfan of it.
No, I'm just talking about the pectus deformity itself. What are the clues on the frontal view that, this patient
Is
might
it the
have
angulation
pectus?
of the interior ribs?
Yeah, so the anterior ribs point down, so the anterior ribs seem to be directed more inferiorly than normal. So that's one thing. And the other thing is that the heart is displaced to the left. You see, the right heart border is missing here. So those are the clues on the frontal view that you may be dealing with pectus. And then, of course, the lateral view is very easy. You see that the sternum is posteriorly displaced. Now, you mentioned Marfan's and abnormalities of the aorta that can be associated with Marfan's and pectus. What else might be associated with pectus in terms of the heart? And also Marfan's, right? Mitral valve prolapse. So that we can also see. So here in this case, we have the dilated ascending aorta here. You see the jet going back into the left ventricle from aortic regurgitation, tulip bulb sign. All of these things can be associated with Marfan, and sometimes pectus deformity might be the finding on the plain film that might point you in that direction. Okay, also mitral valve prolapse can also be seen in these patients. So rib notching, of course, coarctation of the aorta, too few or too many ribs, Down syndrome, endocardial cushion defects, of course, are associated with Down syndrome. Pectus excavatum, we talked about that, Marfan's, aortic regurg, annular aortic ectasia, mitral valve prolapse. Bulging sternum, or pectus carinatum. So you can see that with left to right shunts from the increase in the pulmonary blood flow. Radial ray abnormalities, Holt-Oram, ASD, VSD, limb vertebral anomalies, bacterial syndrome can be associated with VSD. Of course, those letters, what do they stand for? Vertebral, right? Anal atresia, right? Cardiac. Yep. T fistulas. Renal. Limb, right. Osteogenesis imperfecta, that can be associated with aortic regurgitation. Polydactyly can be associated with Ellis Van Creveld syndrome, which is associated with common atrium. So that's skeletal anomalies. Now, what about situs? When we use the term situs, what does that term situs mean, just in general? The term situs is, what does that generally mean when we're talking about situs? So the term situs has to do with the configuration of the organs in the body, right? So of course it can be normal, it can be abnormal. But when we're talking about specific organs, if we're talking about the heart, if we're talking about the situs of the heart, what does that mean? How do we define the situs of the heart?
Apex pointed to the left.
No.
Where
The apex and the ventricles have nothing to do with situs of the heart itself.
think it's like industrial. Yeah, right atrium.
The atria, right. So it's the atrial positioning that are related to cardiac situs. Okay. So when we're talking about situs of the heart, we're talking about the atrial positioning. And because the atria form very early in embryology, differentiate early, and they develop their connections, especially to the inferior vena cava, the lungs. And so that's why it is the situs of the atria that is associated with the position of various other organs within the body. The ventricles take their positions later. So when we're talking about situs of the heart itself, we're referring to the atria, what the morphologic right atrium, the morphologic left atrium. So where do they lie? So in terms of the way we can describe situs for the atria, we can have situs solitus for the atria, meaning that the right atrium is on the right side, the morphologic right atrium is on the right side, the morphologic left atrium is on the left side. Okay. The morphologic right atrium tends to be on the same side of the body as what organ in the abdomen? The liver. The morphologic left atrium tends to be on the same side as the spleen, right? As far as the lungs go, the morphologic right atrium is on the same side of the body as the trilobed lung, right? The lung with 3 lobes. And the morphologic left atrium on the same side as the lung that is bilobed. And you also have to be familiar with the terms eparterial bronchus and hyparterial bronchus. That often comes up on examinations, right? So when we're talking about situs solitus, normal configuration, the right atrium is to the right of the left atrium. The right atrium on the same side of the body as the liver, the trilobe lung, and the eparterial bronchus, meaning the bronchus that goes above the pulmonary artery. Left atrium, same side of the body as the spleen and the bilobe lung. When we have situs inversus, then the right atrium is to the left of the left atrium. The morphologic right atrium is to the left of the morphologic left atrium. And then again, the left atrium, same side as the bilobe lung here. The morphologic right atrium, the same side as the trilobe lung, where the liver is on the left side, the spleen is on the right side. So these configurations that you may be familiar with, right? So the normal positioning here, and then situs inversus, which we think of as the mirror image of normal. But then you can have configurations where it's very difficult to figure out what's going on here in terms of the liver. It looks like we have a midline liver. It looks like the stomach is here. The heart, what's going on with the heart? Very confusing. So the term used for this, when the configuration of the organs is confusing, is what? Situs ambiguous, right. And when we get to situs ambiguous, there are two major syndromes that are associated with situs ambiguous, and those are polysplenia and asplenia, right. So when we talk about asplenia, so here the atria, both atria, or this is also called bilateral right-sidedness, both atria morphologically resemble morphologic right atria, okay, bilateral right-sidedness. The liver often in the midline, no spleen, that is asplenia. Polysplenia, also called bilateral left-sidedness, where both atria resemble morphologic left atria, and you have two bilobe lungs, bilateral left-sidedness, and these patients have multiple spleens, so that's called polysplenia. Now, I told you that the best way to identify the morphologic right atrium is what? What?
Inferior vena cava.
The chamber that receives the inferior vena cava, right? So what happens in a condition like polysplenia, where the spleen, where the atria resemble bilateral left atria, where it doesn't look like you have a right atrium? What happens then?
You get a zygous continuation.
Right, there is no IVC. This syndrome is associated with azygous continuation of the inferior vena cava. So you don't find an IVC returning to the heart. Instead, you have azygous continuation. So that's kind of nice. Which is worse, asplenia or polysplenia? Yeah, I mean, if you had to guess, you're better off having too many spleens than not having any, right? So asplenia is worse. But also because of the severe congenital cardiac defects that tend to be associated with asplenia. So the one that is associated with asplenia particularly is what? Very bad congenital total anomalous pulmonary venous return. Polysplenia tends to have milder congenital cardiac defects, especially septal defects. So of these, the one that you're more likely to come across in an adult patient is polysplenia. So asplenia is usually going to be diagnosed in infancy. Right? So that's situs ambiguous. And again, just looking at the plain film, you can usually tell that there's something wrong, right? Usually, if the stomach and the stomach bubble and the apex of the heart are on different sides of the body, it's usually an indication that there's something seriously wrong with this person, right, when you're looking at the plain film. We're used to the normal configuration. We're used to the mirror image of normal, not so used to this stuff, okay? All right. So getting back to the radiographic findings when we're dealing with, more normal looking chest radiographs, the most important thing is the pulmonary vascularity. That's where we start when we're dealing with congenital heart disease from the plain film. And then we'll talk about cardiomegaly versus near normal heart size. So these two things can determine the algorithm, the differential pathway that you're going to use in terms of what entities you're going to discuss. The clinical data here also very important, whether the patient is cyanotic versus acyanotic. Once you have these three, then you have a roadmap in terms of a differential to approach. Presence of symptoms, CHF, whether they're symptoms of CHF, this of course can also help, but the most important thing is the pulmonary vascularity, whether the patient is cyanotic or acyanotic, and then cardiomegaly versus near normal heart size. From here, once you have those three bits of information, you can give a reasonable differential diagnosis. So when we're talking about the status of the pulmonary circulation, so regarding the radiographic appearance of the pulmonary circulation in congenital heart disease, the three abnormal states of pulmonary vascularity. What are these three abnormal states? Increased vascularity, right? Decreased vascularity. And the third state is pulmonary, no. Normal is not abnormal, right? Remember, see right, pulmonary venous hypertension, right? The question asks the three abnormal states. Pulmonary venous hypertension or failure is the last. So increased vascularity, over circulation, that means there's increased pulmonary blood flow. Decreased pulmonary arterial vascularity, there's decreased pulmonary blood flow. Pulmonary venous hypertension, signs of failure, pulmonary edema, interstitial lines, etc. If the pulmonary vascularity appears normal, but the patient is cyanotic, we will consider that as far as a plain film equivalent to decreased vascularity. Okay? So, when we look at the plain film and we're dealing with congenital heart disease, we always start with, well, assuming we've gone through that part of it. What did we say we'd like to start with? The pulmonary vascularity. So in terms of the pulmonary vascularity here, what category would you put it in? Increased, decreased, or failure? Increased, right. So the pulmonary arteries are big. You see the vessels going out to the periphery. We don't really see pleural effusions, curly B lines, signs of failure. What's the important question you need to ask at this point? Yes. So here you ask the question, is the patient cyanotic or not? That's going to determine your first differential in terms of, your differentials of what you're going to give. So this patient was not cyanotic, so this was from a left to right shunt. In this case, it was from a ventricular septal defect, which you can see here. Okay? So here, what do you think of the pulmonary vascularity? This is decreased. What question do you ask?
Cyanotic or not?
Do you have to ask that question?
I guess not.
No, because if the vascularity is decreased, they will all be cyanotic. Okay? So in this case, you don't really have to know. If you're going to say the vascularity is decreased, all of those patients are cyanotic, right? So you don't need to ask that question. Decreased pulmonary arterial vascularity, those patients are always cyanotic, okay? Now, some of you don't blurt it out, but there's some nice plain film finding here that gives away the diagnosis, but we'll get to that, okay? Here, what do we think of the pulmonary vascularity? What would you say here? Is this increased vascularity, decreased vascularity, or does this look like failure? Yeah, do we have pleural effusions? Yes, we have some small effusions. These look like interstitial lines, interstitial edema, right? Now, realistically, if you're looking at this, in the morning, right, it's probably more likely to be meconium aspiration, right? When you have a chest radiograph that looks like this, but in the setting of congenital heart disease here, in terms of illustrating, right, this is failure. Notice, by the way, the heart size is normal, right? Heart size is normal. That's an important point. We'll get to that again a little bit later on. So, pulmonary venous hypertension failure, okay? Now, if we have increased pulmonary vascularity and the patient is acyanotic, we're in a particular category of lesions. What category are we in? Left to right shunts. And in that category, the three most common are Right, ASD, VSD, PDA. So from those two bits of information, increased vascularity, patient is not cyanotic. Now we know left to right shunts, the three biggies, ASD, VSD, PDA. Right? That's your differential. That's where you start. Okay? Atrial septal defect, ventricular septal defect, patent ductus arteriosus. We'll get to these in more detail in a future lecture. Okay? Now, if there is increased vascular acyanotic left to right shunt, depending on the amount of the shunt, sometimes the pulmonary circulation can be overwhelmed. Sometimes those patients can go into congestive or pulmonary edema because of overwhelming the blood flow with a large ventricular septal defect or a large amount of shunting. The degree of cardiomegaly on the plain film is usually proportional to the increase in pulmonary vascularity from volume overload. This is important that by the time we can notice a difference in the plain film, by the time you notice that there's increased pulmonary vascularity, you already need at least a 2-to-1 shunt. So don't be surprised if the plain film is perfectly normal and they tell you the echo shows an ASD or the echo shows a ventricular septal defect. You need a fairly large shunt, at least 2-to-1, before you actually see these changes on the plain film. So the plain film is relatively insensitive to small amounts of shunting. All right, so if we have increased vascularity, acyanotic, we're in the category of left to right shunts. Now we can look at the heart. We can look at specific chambers. So with an atrial septal defect, what chambers are enlarged? Right atrium and right ventricle. Right, ASDs give you right heart enlargement. Partial anomalous pulmonary venous return. What chambers are enlarged? Also right atrium. So you could put that on the same neuron as atrial septal defect to save space as you're cramming all this information into your heads. Okay? So this gives you the same plain film findings as this in terms of increased vascularity, acyanotic, but there's enlargement of right-sided chambers. Ventricular septal defect. What chambers are enlarged?
Right ventricle.
Right ventricle. What else?
Right.
Nope. Left ventricle. Left atrium. Right? So that gives you enlarged left atrium, left ventricle, and the right ventricle. Remember, with a ventricular septal defect, the shunting is occurring at the ventricular level, not the atrial level. Right? With endocardial Cushing defects, if you have a partial or mild form of endocardial Cushing defect, that can simulate an ASD. If you have a complete endocardial Cushing defect that gives you a large amount of shunting, that will simulate a VSD. If you have a PDA, what chambers are enlarged? Left atrium and left ventricle. Now this becomes very easy. Just remember, ASD, right heart enlargement. PDA, left heart enlargement. VSD, biventricular and left atrial enlargement. One other very important thing to remember is that if the left atrium is not enlarged, what kind of shunt are you dealing with?
Right to left.
No, we're dealing with left to right shunts here, right? But which one of these, if the left atrium is not enlarged? ASD, right? So if you're in this category and you don't think the left atrium is enlarged, you think there's right heart enlargement, then you're dealing with an atrial septal defect, okay? So we always start with vascularity, which is, in this case, increase. The question you ask,
Cyanotic.
yeah, this patient is not cyanotic. We're in the category of left to right shunts. The three biggies are ASD, VSD, PDA. Now we look at chamber enlargement, particularly what chamber do you want to look at? Left atrium. That could help you right away. Is the left atrium enlarged in this patient? That's what the contrast in the esophagus can help you with, right? So you see that the contrast here is not really bowed forward in the esophagus. So the left atrium is not enlarged, right? We do see encroachment on the retrosternal clear space, right? So the right-sided chambers are enlarged. So that means we're favoring what in this case? ASD, right? So here we're favoring atrial septal defect, right? In this case, we start with pulmonary vascularity. We think it is increased. We ask,
Cyanotic.
and this patient is not. You're in the category of the three biggies are. Now you look at the left atrium, and what do you think? What's happening to the esophagus? Yes, so here the left atrium is enlarged, which means you will consider here VSD and PDA are the ones that you would consider for this particular patient. Okay? And in this particular patient, this was a ventricular septal defect. Now, pulmonary vascularity here. Well, you have three choices: increased, decreased, or pulmonary venous hypertension. You think that's decreased? See all these blood vessels here very nicely? So, we didn't get there yet. Increased, decreased, or failure? Increased. Now we ask, and this patient is cyanide. Interesting. All right? So now, what category are we in? Now we're in the category of
Right to left side.
admixture lesions. Right? There's shunting in both directions, left to right and right to left. It's the left to right shunting that gives you the increased pulmonary vascularity. It's the right to left shunting that gives you the cyanosis. So these are admixture lesions with bidirectional shunting. If the pulmonary vascularity is increased, we also know that there's no obstruction of the pulmonary blood flow, right? Because the pulmonary vascularity is increased. So do we think the patient has pulmonic stenosis? No, there's no obstruction of the blood flow. When we're in this category of admixture lesions, right, there's a particular letter that we think of. These are called the T lesions. The T lesions, right? What are the T lesions? Name the T lesions. Transposition, truncus, toenamus pulmonary venous return. Those are the three big ones. Invariably, somebody will blurt out tetralogy, and I will say, terrible choice. Why? Why? Yeah, tetralogy gives you decreased pulmonary blood flow. It's not in this category, even though it begins with a T, so don't make that mistake. Tetralogy is not one of the T lesions that are in this category. But the three big ones that you have to know are, you said, transposition, truncus, and toenamus pulmonary venous return. You want to know those three, okay? So, we discussed the pathology there. We talked about what some of those T lesions are. Make sure you don't blurt out tetralogy of Fallot, right? The three big ones, transposition, truncus, toenamus pulmonary venous return. Some other ones, tricuspid atresia with large VSD, no pulmonic stenosis, single ventricle without pulmonic stenosis, hypoplastic left heart, which really falls more in the category of failure, double outlet right ventricle, common atrium, just some other ones that are thrown in there. But these three you have to know, all right? Those are the ones that are most likely you'll be asked about. A nice mnemonic, 5 T's in CAD, 1, 2, 3, 4, 5. Common atrium, aortic atresia, hypoplastic left heart, double outlet right ventricle, okay? Not tetralogy of Fallot, okay? Do not make that mistake. So, the three biggies, detransposition, truncus, toenamus pulmonary venous return. When we use the term transposition, if somebody uses that term transposition, what does that mean? How do you interpret the word transposition in the setting of congenital heart disease? What do you say to yourself when you hear the word transposition? You say what? Ventricular arterial discordance. That's all it means. All right? So it means a morphologic right ventricle is connected to aorta, and a morphologic left ventricle is connected to pulmonary artery. There are two flavors of transposition. There is detransposition, which is what we are talking about here in this category, but there is also L transposition, or congenitally corrected transposition, that we will get to later. Okay? But both of them, when they use the word transposition, means ventricular arterial discordance. That's what transposition means. So don't get confused about the aorta is here, the pulmonary artery is here. No, just ventricular arterial discordance. And you'll hear the word transposition. And then there are two flavors, D or L. Okay? So getting back to what we started with. So the patient is cyanotic. We're in the category of the T lesions. The three biggies are, start with transposition because that's the most common, right? Total anomalous pulmonary venous return and truncated. Now, there's a nice plain film finding here that helps you, right, when you're in this category. What's the plain film finding? What is it called? Egg on a string, right. The egg is what's the egg? The heart. The heart's big, right? The string is the narrowed mediastinum, right? So the egg on a string is associated with transposition, right? So this is the plain film finding of transposition, the egg on a string sign. Why is the mediastinum narrowed in transposition? Two reasons. One, usually in infants, when we look at the mediastinum, there's this big blob sitting over there, which is thymus, right? Whenever infants are stressed, they get thymic atrophy. So that's one thing that happens. The second reason is that in transposition, the great vessels tend to be superimposed on each other. That further narrows the mediastinum in terms of where they are. Okay? So the narrow mediastinum with the big heart is the egg on a string that is associated with detransposition. The egg on a string. Okay? All right, detransposition. These patients have to have shunts to survive, otherwise the two circulations are completely separate. So they'll have various combinations of VSD, PDA, atrial septal defects. Okay, that's to allow the two circulations to communicate. Otherwise, they would be completely separate, and that's incompatible with life. But they will be cyanotic, right? And often right-sided cardiomegaly, because the right heart here, the right ventricle, is pumping against the aorta, systemic vascular resistance. All right, cyanotic. Told you that, but we start with blood flow. The blood flow here is I'll tell you it's increased. Patient is cyanotic. So the three big lesions are
Total anomalous pulmonary
And-
return and truncated.
right. Now there's a plain film finding here that helps you. What is the plain film finding?
Widened mediastinum.
The snowman sign, right? And that goes with, right. Why do we get a snowman with total anomalous pulmonary venous return? What gives you the heart itself is big, right? The heart's big, but what gives you the snowman? What gives you all this stuff in the mediastinum? Right. You have this, the pulmonary veins, when they return, form this vertical vein that comes up, joins the brachiocephalic vein, and then into the superior vena cava. You have all this increased blood flow in here, and that gives you this part of the snowman, the head of the snowman. So it's total anomalous pulmonary venous return type 1. Right. Supracardiac. Okay? Snowman sign. Total anomalous pulmonary venous return. So the pulmonary veins, instead of draining to the left atrium, they form a common pulmonary vein, this vertical vein that joins the left brachiocephalic vein into the superior vena cava. That is total anomalous pulmonary venous return type 1. That gives you the snowman sign. Okay? So these patients, this chamber becomes the chamber where everything mixes, and then they have to have an atrial septal defect to get the blood across. So here are the pulmonary veins forming this vertical vein, left brachiocephalic vein, superior vena cava. This is what gives you a snowman on the plain film when you're dealing with total anomalous pulmonary venous return. Another patient who has increased pulmonary blood flow, who's cyanotic, go through the exercise, the big three. Which of those three is this? Well, the big three, yes, it's the one we haven't done yet. So what is truncus? What is truncus arteriosus? What does that mean?
It's like the aorta and pulmonary artery don't split.
Yes. So the aorta and the pulmonary artery are not separated. You have one common vessel, which is the truncal vessel here, and that sits on top of a, what does it sit on top of? It sits on top of a ventricular septal defect, which means it receives blood from both ventricles, right? So both ventricles empty into this truncus, and then from here, it separates into the aorta and the pulmonary artery. Okay? So you have one common vessel, the truncus, sitting on top of a ventricular septal defect, receiving blood from both ventricles. That's where all the mixing occurs. And then the pulmonary artery comes off of that. That's truncus arteriosus. Okay? And if there's no pulmonic obstruction, they will have increased pulmonary blood flow. They will be cyanotic, persistent truncus arteriosus. This, we start with the pulmonary blood flow. Here it is decreased. Do you have to know if the patient's cyanotic? No, right? So the heart size here is near normal, but there's a very nice plain film finding that kind of gives away the diagnosis here. What's the plain film finding? When you look at the heart? The boot-shaped heart, right. So what does that mean, boot-shaped heart? Yeah, so it's associated with tetralogy, and it's right ventricular enlargement. The apex elevates here, and that gives you the boot-shaped heart, and that, of course, is associated with tetralogy of Fallot. The boot-shaped heart is a plain film finding associated with tetralogy. There is a differential diagnosis, and the differential here is tetralogy-like lesions, right? Lesions that have the major things in tetralogy, right? When we say tetralogy of Fallot, the four things are. What are the four things that make up tetralogy? Infundibular stenosis, right? Stenosis of the outflow tract of the right ventricle. What else? VSD. What else?
Overriding aorta.
Overriding aorta. What else? Right ventricular hypertrophy. Those are the four. You only really need two of those, and then you have the other two. The two fundamental defects that you need are what? Infundibular stenosis and VSD. Once you have infundibular stenosis and ventricular septal defect, the aorta will be moved over and it will sit on top of the VSD, right? So that comes with that. And of course, if you have outflow obstruction of the right ventricle, you will get right ventricular hypertrophy. So the two fundamental things for tetralogy of Fallot are the infundibular stenosis and the VSD. So any congenital cardiac defect that has those two things, regardless of what else you have, if you have obstruction of the outflow of the right ventricle and you have a VSD, you will have tetralogy-like physiology. And that will resemble tetralogy of Fallot on the plain film and also clinically. Okay? And of course, there's a bonus finding in this case. Those of you with the sharp eyes also notice the other finding that's associated with tetralogy here, which is the right aortic arch. That is also associated with tetralogy. Okay? So this patient also has decreased pulmonary blood flow. We know the patient's going to be cyanotic, but as opposed to the plain film of tetralogy, what's different in this case? Remember, in tetralogy, the heart size was near normal, right? But here we have, there's cardiomegaly here, particularly what chamber? Right atrium. This guy over here, the right atrium. Okay? So as opposed to the tetralogy-like physiology, these patients tend to have something else. So here, there tends to be right to left shunting at the atrial level, causing right atrial obstruction, causing the right atrium to enlarge. And we'll talk about the lesions that are in this category when you have cyanosis with decreased blood flow and cardiomegaly as opposed to the tetralogy-like lesions. So when you have decreased blood flow, of course, they will be cyanotic. There's a difference between cardiomegaly, the big heart, the lesions that we think about here, and the lesions that we think about here. So here we think about tetralogy of Fallot-like lesions, and here we'll talk about Epstein's and some other things that can give you this appearance. Okay? So usually what you have here is that there's a obstruction to blood flow in all of these cases. When we have decreased or normal vascularity with cyanosis, there's obstruction to pulmonary blood flow, and there's an intracardiac right to left shunt. It just depends where it is. With the tetralogy-like lesions, it tends to be at the ventricular level. With these lesions, where you have cardiomegaly, it tends to be at the atrial level. Okay? So tetralogy of flow, we've talked about the abnormalities, the fundamental abnormalities, those obstruction of the outflow tract and the ventricular septal defect. This allows the aorta to shift over and sit on top of this, receiving blood from both ventricles, and that's what gives you that right to left shunting. And of course, the obstruction to the outflow here is what gives you the right ventricular hypertrophy. Okay? So that's tetralogy, basically. When we have cardiomegaly, usually the ventricular septum is intact, and the right to left shunting occurs at the atrial level. And so if that atrial septal defect or pain foramen ovale, not very large, the right atrium can enlarge here, and that gives you the enlarged right atrium. And the classic lesion in this category is Epstein's. And we'll talk about Epstein's in a little bit too. Okay? So no cardiomegaly, tetralogy of Fallot, or any admixture lesion with pulmonic stenosis that has especially a ventricular septal defect. And then we have tricuspid atresia with a large ASD and pulmonic stenosis, and in this weird thing, pulmonary atresia with intact ventricular septum type 1. So we'll talk about that in a minute too. But your classic tetralogy-like film, decreased vascularity, upturn to apex, and then the bonus of the right aortic arch. All of these lesions look like tetralogy on the plain film, but they all have, these are all admixture lesions. They all have some form of VSD and pulmonic stenosis. Single ventricle with pulmonic stenosis, transposition, double outlet, tricuspid atresia with pulmonic stenosis. They all look like tetralogy, but once you have a VSD and pulmonic stenosis, the physiology and the plain film appearance will resemble tetralogy. Now, if we have cardiomegaly, the right atrium tends to enlarge, and the here, Epstein's anomaly is the big lesion in this category. Tricuspid atresia with a restrictive ASD. This occurs in infants, critical pulmonic stenosis with an ASD or pain foramen ovale, and then this weird thing, pulmonary atresia with intact ventricular septum type 2. So let's talk about Epstein's first, since this is the classic lesion in this category. Decreased vascularity, patient is cyanotic, of course, enlargement of the right atrium, and then sometimes there's a particular descriptive term that's used for this when the heart looks like this. What is that term? Box-shaped heart or wall-to-wall heart. Okay? So those are the terms used to describe Epstein's anomaly. So what happens with Epstein's is a malformation of the tricuspid valve. So it's displaced too far to the apex because it never really peels completely off of the interventricular septum. And so what happens is you get tricuspid regurg and a relative obstruction to flow through the right side of the heart. So this is called the atrialized portion of the right ventricle because it functionally functions like the atrium instead of the ventricle. The functional portion is small. And so you get right heart enlargement. Often these patients have an ASD or pain foramen ovale, and so they will get right to left shunting, and that's what gives them the cyanosis. And the big heart is right heart enlargement from enlargement of the right atrium and the atrialized portion of the right ventricle. So that's the classic Epstein's. Okay. Now here's a pathognomonic finding that you might see on imaging for this particular congenital heart disease. What do we see here?
Is this a hypoplastic right heart?
Yeah, the right heart is small, but why?
Tricuspid atresia?
Yeah, how do you know it's tricuspid atresia? Well, there is no, this guy here is the mitral valve. There is no tricuspid valve, right? Tricuspid atresia. So there's no communication from the right atrium to the right ventricle. That's why the right ventricle is small. If there's decreased blood flow through a vessel or a chamber in embryology, that chamber will not develop. That will be small. So there's fat where the tricuspid valve should be. And another nice clue is, what is this guy in here? What is this guy? See that guy? What is that guy? That guy right there. What is that? Why is it bright? Why is there a flow void?
RCA.
That's the RCA. So notice that the RCA should be out there. But the RCA, because of the tricuspid atresia and the fat here, has been moved into that groove, into that atrioventricular groove. Okay? So this is a patient with tricuspid atresia. It's a very complicated abnormality, tricuspid atresia. And the right ventricle, we've talked about why the right ventricle is small in these cases. There are two flavors of this, that type, when it's associated with pulmonic stenosis and when there is no pulmonic stenosis. This type tends to be associated with transposition. This type tends not to be associated with transposition. But when there is pulmonic stenosis, here there will be cyanosis with decreased pulmonary blood flow, and this will kind of can resemble here tetralogy of Fallot sometimes. Here there will be cyanosis with increased pulmonary blood flow. So this is how tricuspid atresia can occur in both categories of increased pulmonary blood flow and decreased pulmonary blood flow because of the associated abnormalities with tricuspid atresia, whether or not there is pulmonic stenosis. Okay? And then also the size of, so you can see here with pulmonic stenosis here, decreased pulmonary blood flow. Here in this case, it looks like tetralogy of Fallot. Without pulmonic stenosis here, there's increased pulmonary blood flow with a big heart. Right? So this falls more into that admixture lesion category. And then also the size of the ASD determine how big the right atrium gets. If you have a restrictive small ASD, the right atrium can get bigger. And if it's not so restrictive, then the right atrium does not get so big. So this can also affect how big the heart looks with tricuspid atresia. So tricuspid atresia can be very confusing and falls in different categories because of the associated abnormalities. And then there's this weird thing, pulmonary atresia with intact ventricular septum. There is a type 1 and a type 2, and that has to do with whether the tricuspid valve is competent or incompetent. With type 1, the tricuspid valve is competent, so you get a small right ventricle. With type 2, it's incompetent, and you get tricuspid regurgitation, so the right ventricle enlarges. Both of these will have decreased pulmonary blood flow. Of course, both of these will be cyanotic. This one will give you a big heart. This one will give you a more normal-sized heart. So this one will fall in that category where it resembles tetralogy of Fallot, and then this one in that category where the heart is bigger, where it can resemble Epstein's as far as the plain film appearance. Okay? So type 1, regular sized heart, type 2, big heart. This both have decreased pulmonary blood flow. This can look like tetralogy on the plain film. This can look like Epstein's on the plain film. Pulmonary venous hypertension. Both of these patients have failure in pulmonary venous hypertension and pulmonary edema. But what's different when you look at the radiographs?
Heart size?
Yeah, the heart size. Here the heart is big. Here the heart is normal in size. So what is the significance of that? That when you're in this category of failure, what is the significance of whether the heart size is normal or whether it's big in terms of the differential?
This is Eisenmenger?
No, this is not Eisenmenger. This is failure. And then failure here that we're talking about neonates, babies.
If the heart is small, the obstruction is.
Yeah, so this, right, so this has to do with if you have a congenital cardiac malformation, if the heart is normal in size, then there's an obstruction at or proximal to the mitral valve. If there's a congenital cardiac abnormality that leads to a big heart in failure, and if there's an obstruction, then the obstruction will be distal to the mitral valve. when the heart gets big. And there are some other things also in this category, like anything that causes heart failure will give you a big heart, of course, and pulmonary edema. So the differential diagnosis can be a little more extensive when you have a big heart and failure in these babies. So no cardiomegaly obstruction at or proximal to the mitral valve, cardiomegaly obstruction distal to the mitral valve, cardiomyopathy, or any cause of left ventricular failure. So any cause of left ventricular failure can give you a big heart with pulmonary edema, of course. Right? So this patient has pulmonary edema and cyanosis, but the heart size is normal. And this question comes up, very nice quiz question here. When the heart size is normal and the patient has pulmonary edema and cyanosis, what is the lesion you're supposed to think about here?
I think it's a TAV.
Yeah, total anomalous pulmonary venous return type 3 below the diaphragm, okay? And so what happens there is that the total anomalous pulmonary, the veins drain below the diaphragm, usually into the portal vein, and the flow is obstructed. And because that flow is obstructed, it builds up the pressure here. The pressure, of course, is transmitted backwards into the pulmonary circulation. And so these patients develop pulmonary venous hypertension and failure. Right? So cyanosis, normal heart failure, total anomalous pulmonary venous return below the diaphragm because the vein gets obstructed. Right? So the role of the ductus venosus here is very important because in embryology, or especially in the first few days after birth, the ductus venosus remains open. And so what happens is, even though this is draining to the portal vein, from here it can shunt into the inferior vena cava without much obstruction. But once the ductus venosus closes, then all of the resistance here, as it has to go through the liver, increases. And so then they develop the pulmonary venous hypertension and the failure. Okay? So as long as the ductus venosus stays open, they may not have so much in the way of pulmonary venous hypertension, but once it closes, they can go into failure. So that's total anomalous pulmonary venous return type 3, drainage below the diaphragm. There are other reasons why it might cause obstruction, but this gives you normal heart size and failure. Okay? Without cardiomegaly, there are some other things also in this category, such as choroid triatum, congenital mitral stenosis, pulmonary vein atresia, relatively rare. This is the one that often comes up on your exams, total anomalous pulmonary venous return type 3, especially if there's cyanosis. These will not be cyanotic. Pulmonary edema, cyanosis, and a big heart in a newborn. Okay, so here, what congenital cardiac defect do we think about here? And it's the most common cause of congenital cardiac death in the newborn period. What lesion?
Cardiomyopathy.
No, it's not cardiomyopathy here. They have cyanosis. So it's a congenital cardiac defect. Yeah, hypoplastic left heart. So here you have hypoplastic left heart. But if the left heart is hypoplastic, why is the heart big on the plain film? It's the right sided enlargement that gives you the big heart on the plain film. So with hypoplastic left heart, this usually occurs because there's some obstruction of blood flow here at the mitral level. So the left ventricle is small. And because the left ventricle is small, the ascending aorta does not develop. So you get aortic stenosis or atresia. Often they might also have interruption of the aortic arch, obstruction here at the mitral valve, mitral atresia, and a hypoplastic left heart. Which means then what happens is that the right heart starts pumping for both circulations. The right heart pumps into the pulmonary artery, goes through pink ductus arteriosus, and that's what perfuses the aorta. Okay, so the right heart fails, and they'll also have increased, of course, pulmonary venous pressures because of the obstructions on the left side, and so they go into failure. So it's the most common cause of cardiac death in the first few weeks of life. So the ascending aorta is small here with hypoplastic left heart. Here, when you inject the pulmonary artery, the contrast actually goes from the pulmonary artery through the pink ductus arteriosus into the aorta. So the right ventricle is pumping really for both sides of the circulation, right? pumping systemically in this case because it's going through the PDA into the rest of the aorta, and the right ventricle also fails. Right? So that's hypoplastic left heart. Now, there are other causes of left heart failure, right? So when you have obstruction distal to the mitral valve, cardiomyopathy, left ventricular failure, all of these will give you a big heart, and all of these can give you pulmonary edema. Not necessarily cyanosis, but all of these can give you pulmonary edema. Right? Hypoplastic left heart will give you cyanosis, but these obstructive lesions can result in pulmonary edema if they're severe enough, and then these diseases affecting the myocardium, systemic AV fistulas, high output failure, and anomalous left coronary from pulmonary artery. We talked about that also. That can also result in failure. So all of these will give you a big heart and failure in infants. Okay? So severe coarctation, of course, the heart gets big, fails, pulmonary edema. They don't get cyanosis though, but they will have a big heart and pulmonary edema. Okay? Aorta and pulmonary artery, sometimes you can hit a home run if you notice this. So the pulmonary vascularity here is decreased, but the patient has a right aortic arch. So what lesion do we think about?
EOF.
Tetralogy of Fallot, right. Here the pulmonary vascularity is increased, but again, the patient has a right aortic arch. So here, what lesion do you think about?
This total anomalous pulmonary venous return.
No, which admixture lesion is associated with right arch? Truncus arteriosus, right. Of all patients with truncus, 35% have a right arch. Of all patients with tetralogy, 20% have a right arch. These are the other ones. I've given that to you in your handout. But because tetralogy is much more common than truncus arteriosus, that if you have a right arch and congenital heart disease, you're more likely to run into cases of tetralogy than truncus. But we've talked about truncus gives you increased blood flow unless there's pulmonic stenosis associated with that. Tetralogy gives you decreased blood flow. So you shouldn't confuse the two, right? But both of those are associated with right arch, okay? And then I've given you this in terms of the distribution of congenital heart disease that we can also see, all right? So your survival guide, increased pulmonary blood flow, no cyanosis, left to right shunts. Cyanosis, admixture lesions, the T lesions, make sure you know these three, not tetralogy. Decreased pulmonary blood flow, no cardiomegaly, start with tetralogy or tetralogy-like lesions. They have a VSD and pulmonic stenosis. This weird thing, pulmonary atresia with intact septum type 1. If there is cardiomegaly, the big thing there is Epstein's, a few other things that are also thrown in there, right? But this is your survival guide. Memorize this in terms of how to approach the plain film, okay? And you can give a reasonable differential diagnosis. Pulmonary venous hypertension, no cardiomegaly, obstruction at or proximal to the mitral valve. If there is cyanosis, total anomalous pulmonary venous return type 3. Cardiomegaly, obstruction distal to the mitral valve. If there's cyanosis, hypoplastic left heart. Cardiomyopathy, any cause of left ventricular failure. Of course, these will not have cyanosis, but these will give you cardiomegaly and failure, okay? So, pulmonary circulation, increased. What question do you ask? Is the patient, so if the patient is not cyanotic, we're in the category of left to right shunts, right? So now you'll look at the heart, chambers, what do you think? Yeah, it looks like maybe there's some right heart enlargement. Do you think the left atrium is big or not? So what do you go on? What's the answer? AST as an atrial septal defect, and here you have your right heart enlargement, okay? All right, so here, pulmonary circulation increased. I'm telling you the patient is cyanotic. You're in the category of admixture lesions, the three big ones there. Total anomalous pulmonary venous return. Looking at the plain film, what might you favor? Why are you saying tall anomalous pulmonary return?
It's kind of like a snowman.
Maybe kind of like a snowman? What else could this be over here?
Right aortic arch.
If it's a right arch, what would it be then? What's the answer? Truncus arteriosus, yeah. So here's your VSD, there is your truncus, there's the aorta and the pulmonary artery. Right? Okay. This patient, pulmonary circulation, decreased. Patient is cyanotic. What do you favor here and why? Heart, by the way, yeah, heart size normal or near normal, yes. So here you favor tetralogy, why?
Boot-shaped heart.
Boot-shaped heart
Right-sided aortic arch.
and right-sided aortic arch. Right. The components of tetralogy,
VSD, right ventricular enlargement.
right ventricular hypertrophy, ventricular septal defect,
Outflow tract obstruction.
infundibular obstruction, right? Overriding aorta. What does overriding aorta mean?
Over the VSD.
Yeah, so the aorta overrides the VSD, meaning it can receive blood from both ventricles, right? So that's why you get the right to left shunting. It's going into the aorta from the right ventricle, okay? Okay, this guy, pulmonary circulation, little puff. Let's say it's decreased. Okay, good. So the patient is cyanotic. What do we think of the heart size here? Big. Right atrium is enlarged. Right? So what are you thinking about here? Yeah, it could be Epstein's, right? Is there anything else it could be? Does that look like what did we say about hypoplastic left heart? What do you have to have there? Tut, 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 tut. Failure, right? You want failure there, okay? Right. So here, let's see what happens. So we do an angiogram here. Inject the right ventricle. This guy is supposed to be what? It's supposed to go out into the pulmonary artery, but it doesn't. It doesn't go anywhere. It's pulmonary atresia. Instead, it goes backwards into the right atrium. Then from there, it goes across a atrial septal defect into the left atrium. Right? So this is pulmonary atresia with intact ventricular septum type 2. Right, pulmonary atresia with intact ventricular septum type 2. Okay, see how easy this is? All right.